नमस्ते बिटिया, हमेशा खुश रहो बिटिया. A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about hemolytic anemias. Anemia due to reduction in the number of circulating red cells from their premature destructions leads to the development of hemolytic anemia. It can be inherited or acquired. From the clinical point of view, they may be more acute or more chronic. From the severity point of view, they can be mild or they can be very severe. On the basis of site of hemolysis, it can be intravascular or extravascular. With respect of mechanism, hemolytic anemias can be due to intracorpuscular causes or the extracorpuscular causes. Now we come to the classification of hemolytic anemias. It can be due to intrinsic RBC abnormality or can be due to extrinsic RBC abnormality. In the intrinsic RBC abnormality, it can be due to the membrane defect, that is hereditary spherocytosis or hereditary elliptocytosis. It can be due to metabolic defect like the shunt pathways due to glucose 6-phosphate dehydrogenase deficiency or Amdin-Meron pathway, that is due to pyruvate kinase deficiency. It can also be due to hemoglobin defect with structurals like HbS, HbC, Hbe unstable hemoglobins, or due to this defect in synthesis like thalassemia syndrome. Next, we come to extrinsic RBC abnormality that can be due to antibody mediated or non-antibody mediated. In case of antibody mediated, it can be due to the blood group incompatibility, hemolytic blood transfusion reactions like ABO and RH incompatibility, hemolytic disease of the newborn or autoimmune hemolysis, and it can be drug induced. Antibody mediated is due to blood group incompatibility, hemolytic blood transfusion reaction like ABO and RH, hemolytic disease of the newborn, autoimmune hemolysis, and it can be drug induced. In case of non-antibody mediated, it can be due to RBC fragmentations, thrombotic thrombocytopenic purpura, preeclampsia toxemia, infections, Plasmodium falciparum malaria, Clostridium welchi, infectious mononucleosis. It can also be due to chemicals or drugs damage, like oxidant drugs like glucose 6-phosphate dehydrogenase deficiency, dapsone, and burns. A recognition of the hemolytic state. There is evidence of RBC destruction like anemia, spherocytosis, increased urobilinogen, increased unconjugated bilirubin. There can be evidence of increased rate of red cell production like bone marrow expansion, hypercellularity, compensatory mechanism like erythroid hypoplasia, associated effects of the hemolytic states like depletion of folate stores, hypertrophy of the spleen. Now we come to hemoglobinopathies. Hemoglobinopathies are the various disorders that are affecting the structures, functions, and the production of hemoglobin. Structure, function, and production of hemoglobin. The diseases are caused by dysfunction of the gene encoding the globin chains of the hemoglobin molecule. There are different hemoglobins that are produced during the embryonic, fetal, and adult life. Normal hemoglobin is comprised of 2 alpha chain and 2 non-alpha globin chain. Hemoglobinopathies classification. There are 5 major classes of hemoglobinopathies. Number 1, structural hemoglobinopathies. Next, we have thalassemias, thalassemic hemoglobin variants, hereditary persistent of fetal hemoglobin, and acquired hemoglobinopathies. Structural hemoglobinopathies: thalassemia, thalassaemic hemoglobin variant; hereditary persistence of fetal hemoglobin, acquired hemoglobinopathies. Now we come to sickle cell anemia. In sickle cell anemia, it is inherited as an autosomal recessive trait. There are various homozygous only produce abnormal beta chains that makes hemoglobin S, HbS termed as SS, and this results in the clinical syndrome of sickle cell disease. The pathogenesis includes when the hemoglobin S is deoxygenated, the molecules of hemoglobin polymerize to form pseudo-crystalline structures known as dacoids. These distort the red cell membrane and produces characteristic sickle-shaped cells. The clinical features of sickle cell anemia includes hypoxia, acidosis, dehydration, and infection. Irreversibly sickled cells have shortened survival and blood vessels in the microcirculation. This results in a number of acute syndromes termed as crisis and chronic organ damage. Sickle cell anemia consists of 4 different types of crises. First, we have vaso-occlusive crisis. Next, we have sickle crest syndrome. Next is the sequestration crisis, and the fourth one is aplastic crisis. In the vaso-occlusive crisis, this is the most common crisis with plugging of small vessels in the bone that produces acute severe bone pains. This affects the areas of active bone marrow, the hands and feet in the children, so it is called as dactylitis. There is systemic response with tachycardia, sweating, and fever. Next, we have sickle chest syndrome. It is follow-on from the vaso-occlusive crisis, and it is most common cause of death in adult sickle disease. The bone marrow infarction results in fat emboli to the lungs, which causes further sickling and infarction, leading to ventilatory failure if not treated. Next is the sequestration crisis, that is thrombosis of the venous outflow from the organ that causes loss of functions and acute painful enlargement. The spleen is the most common site, with massive splenic enlargement may result in severe anemia and circulatory collapse and death. Last one is the aplastic crisis, with the infection of adult sicklers with human erythrovirus 19 that results in severe but self-limiting red cell aplasia. This produces a very low hemoglobin, which may cause heart failure. Now we come to the investigations of sickle cell anemia. Patients with sickle cell disease have a compensated anemia. The blood film shows sickle cells, target cells, and features of hyposplenism. A reticulocytosis is present with hemoglobin electrophoresis to demonstrate the absence of HbA and the predominance of HbS. The management of sickle cell anemia. All the patients with sickle cell disease to receive prophylaxis with a daily folic acid and penicillin 5 to protect against the pneumococcal infection. There is vaso-occlusive crisis. These are managed by aggressive rehydration, oxygen therapy, adequate analgesia, and antibiotics. There is transfusion with a fully genotyped blood wherever possible. The oral cytotoxic agents, hydroxycarbamazine, has been shown to have clinical benefits in children and adults who have recurrent severe crisis. There is allogenic stem cell transplants from HLA-matched siblings. So this was all about today's topic, sickle cell anemia. In the next lecture, we are going to discuss about thalassemia. This session is powered by Digital Version 2.0 JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.